Bismillahirrahmanirrahim. Alhamdulillah. Rasulullah. I'm really honored and privileged to be with you tonight. I'm very thankful for Dr. Walid, Professor Majdi, uh, Professor Yahya, Dr. Adil, and Dr. Ahmed for their kind invitation to add me to the list of speakers in this refresher courses. And it's with my, I think if we have all other mics muted, it would be better for the noise. Uh, to talk about the impact of simulation-based education in terms of personal and organizational, and especially in general growth. I'm speaking to you from the city of Jeddah. I hope to see you soon, either in your side or in our side. This is King Abdulaziz University, where I'm speaking from now. This is the hospital there. This is our main hospital. This is the greatest asset in my life of my anesthesia team and critical care department. This is the hospital at night. This is the way, if I go out now, I will see this view. So it's with the green cap, the green building. It's the National Day week celebration. In the fourth floor of this hospital, my team, I'm honored to work with the Clinical Skill and Simulation Center. Those are the people, together with the anesthesia department, the various support that I do have for the last 17, 18 years to do a lot of the work in simulation and in anesthesia. So just to preview, this is where we are located at the fourth floor. We wanted to be the benchmark in training and to provide high quality training program. The Clinical Skill and Simulation Center provide a lot of activities, high fidelity simulation and other programs. Starting from basic skills for medical students to high fidelity simulation program, complicated programs. Nationally, regionally, and internationally, the center has been approved and awarded numerous international awards. Of course, as Professor Majdi Khalil said, everywhere it's about quality, demands, even before Corona, but now the chances to train inpatients, given the anesthetic practice, you cannot, it's stressful, hectic, and a lot of unknowns, but the crises are rare, but when they happen, it's very critical. And simulation centers, if you go to any developed country now, you can't find a hospital without simulation center. So if we go back a few years ago, the World Federation of Anesthesiologists, World Health Organization signed the Helsinki Declaration on Patient Safety. Very clear, the role of patients, education, it's there. And that human factors play an important factor in terms of safety to the patient. And anesthesia, as we stand, we are the key role specialty in which significant reduction in mortality has been achieved. So anesthesia is always in the front. So we are not only providing safety in the specialty, but we are providing safety in many areas. Like other speakers, I will start with two simple cases, and then we'll come back to the discussion. We'll come back to these cases. These actually cases that happen under cases that I was involved in different capacities. The first case is a 50-year-old male, came back to the operating room for re-exploration post-cabbage on that day for bleeding. The patient had cardiac arrest on the table with the opening of the chest. CPR was carried on for 25 minutes, no revival. The senior anesthetist came, discovered disconnection under the drapes. The patient sustained post-operative hypoxic brain damage and died. What we do? What went wrong? The second case is very famous. 8-year-old boy booked for fine needle aspiration under general anesthesia at the radiology suite. The patient have arrested, cardiac arrest after 5 minutes after induction. CPR was done for 35 minutes by 15 senior doctors. The patient had return of vitals and return of circulation with room air ambu bag after the 35 minutes CPR. The patient had hypoxic brain injury and subsequently died. So what we do with these doctors? What do you think went wrong? As we know in medicine, it's never one reason to cause damage. The Swiss model, there have to be a lot of reasons. If we look at morbidity, mortality, and anesthesia, we know that we reduce mortality big time. So safety in anesthesia is so high, but we still have frequent morbidities, dental injuries, dural tap headache, nausea, vomiting, patient discomfort, hypothermia, shivering. So avoiding death is not the goal. This is so much achieved. We need to reduce morbidity, mortality. We need to increase safety. And always communication and team dynamics and the structure of the process to reach that level of safety, we need to pay more attention. It's not only to prevent death. Death, if happened, that means a lot of wrong things happen. So if we look at, that's the first question, this is the high risk, Himalaya mountaineering is the highest risk, while commercial aviation is very safe. Anesthesia for ASA class 1, it's near commercial aviation. But medical risk in general, still near road safety. Cardiac and high-risk procedures in anesthesia, ASA 3, 4, somewhere there. So we reduce the risk for low-risk cases, ASA 1 and 2. But still, we have way to go in reducing the risk in terms of general anesthesia care. So this is the naive look. Only one error lead to crisis. So we have to catch the error maker. But most of the times, to have a critical incident, at least 14, 15 critical factors or mistakes could be resulting. So this is the routine care, routine care, routine care. Then you have critical situation, something abnormal. Usually, routine care could continue. Sometimes we do some corrective steps, and then we go back. For example, failed intubation. Then you try with another person, then you intubate. Or you call ENT, they try, they do tracheostomy, then the patient. It's only when there is confusion, you don't know where you are, you think it's just a cardiac arrest, not an esophageal intubation, then you go. So critical situation could happen, still routine care could continue if we have crisis management. So the person approach to punish people, it's usually lead to naming, claiming, shaming, retraining, fire and deportation sometime. That usually does not work because people don't want to make mistakes. That won't solve the problem. It will just make it worse. People will have counter measure of security because they will just hide the problems. And we will destroy a lot of people. So why investigate? The more we investigate critical situations, the more we need to identify what education needed, new protocol, a new system. Usually, as I said, multiple factors from system, from individuals, and the more we build things to stop standardizing, automation, devices, the more we could control. So I'll be talking about these main 4 topics in the coming 30 minutes or so, and then we'll leave time for discussion. So the role of experience in learning. How do we learn? This is very famous in education. We have experience, reflection, then conceptualization, then experimentation. This is the Klopp cycle or exploration learning. This is the way we acquire basic skills. Then we move from advanced beginner, proficient, expert, master This is, the more we go through that cycle, the more that we could see. When actually we work with people, we cannot see everything. We could only see behaviors. But these behaviors will lead to results. These behaviors come from deep learning and from deeper reactions. So in simulation, we would like to go back to the deep learning and deep reactions that we cannot analyze just by seeing. And that's the whole psychology of simulation. One more important thing is the relationship between experience and confidence and competence. A lot of people think it is a straight line. So with more experience, more time, you are more confident and more competent. But we know that's not true. That line is not linear. There is stages. Stage number one with high confidence, low competence, and with no experience. Then the more you practice, first you are unconsciously incompetent. You know, like this block is very easy, or this arterial line is very easy. You don't know it's difficult or need training. Once you fail, you become aware, then you become consciously incompetent. You don't know, then the confidence go down, but you're more aware. The more you do learning, the more you become consciously competent. Then the more you practice, you become unconsciously competent. You just do things without thinking, like driving. The important question, can people go from number 4 to number 3, from unconsciously competent to unconsciously incompetent? Yes or no? A lot of people think no, but it's actually, if people become rusty, disinterested, away from the field, oh, that's what will happen if these things are very rare. How many of us are competent in treating acute local anesthetic toxicity or malignant hyperthermia or intraoperative myocardial infarction? We are all, because we just don't expose to that frequently. So deliberate practice or the ability to go through this cycle always, and that's where simulation, you could always practice rare situations in which you could experience, reflect, conceptualization, develop some concept, and then experiment and go more. It is that amount of conscious reflection that will mean performance will go. The black is the conscious. The unconscious, that we do it for small time of period or not frequently, will not lead to that level of increased level of expertise. If you want a good example of this, is when we use stethoscopes. If you use stethoscope, you graduate from medical college, you are competent level. If you continue to use it, cardiology, you will go there. If you don't use it, you'll go back like orthopedic or plastic surgeons. They could lose it. They could be lower than even their graduation ability. So deliberate practice is a task with well-defined goal, motivation to improve, supervision, and feedback. Especially feedback is very important by self, machine, or an opportunity for repetitive practice or gradual refinement of performance, and the planning to ensure optimal use of time. That's the way that we get expert, is doing the complicated things in an easy, quick, and efficient way. So it's always in simulation. We want to have people improve their reflection in action by reflection on action. So when simulation is going on, there is thinking going in these heads. What we want people, because these are like real, this is you, Walid, I think, in the picture here. So when people are in the situation, it looks really like a real life situation. It's a very valid experience. It is when they sit down, see the videos, then they reflect back on what they were thinking. So this is the reflection on action to improve future reactions in the future. So it is to build awareness of unconscious cognitive routines and emotional reactions. Why you got angry? Develop capability to upgrade and change these routines and help us see future a situation differently. If you want more details about simulation and the psychology behind it, those are very two good reference, and they're available online. So going on to the next part, why use simulation? Of course, it doesn't matter where you practice. Learning by doing, see one, assess one, do one, is becoming less acceptable. You need to be competent, especially for invasive and complicated. Of course, educators, they don't have time to observe as before. So concentrated courses and times, patients stay less in hospital. You just can't rely on patients. Of course, students have lots more technology to learn. And let's face it, I rather go do clinical work than teach. Of course, there are few things, like it's very difficult for me to do fiber optic and let 5, 6 people do it with the eye. But in simulation, you could make all these disadvantage as advantage. Airway manipulation, how could you make difficult intubation elective in the OR? Cardioversion, how would you teach somebody to administer very high risk medications like adrenaline and see the effects? Few things, it's very difficult or sensitive to teach, and few things are very rare. Simulation make these things, there is always never risk to the patient, never risk to the practitioners. You could do common things and very uncommon things. You could make the known conditions known or unknown or underlying conditions. So you could present the same events to different people. You could allow people to make mistakes and then see whether they have that situational awareness. Can they self-correct? Because in real life, by law, you cannot let them without correction. In simulation, you could let people deal with actual equipments, different personalities if they're upset, and also you could use real life stuff. It doesn't matter where you look, everywhere, everybody will look at outcome-based education. So that means we need to be very specific about the outcome. I'm sure you're hearing about workplace assessment, competency assessment, EBA, entrustable professional activities. It's always focused on the competence by design. So people have to be competent by the training, and you will see more on this. I'm sure at the Zamalat, at the fellowships, you have all the list of the procedures that you need to do before you graduate from residency or before you be competent. So this, like the list of in emergency medicine, how can you make sure that you have dislocated shoulder reduction 10 times? So this could be both patient care and simulation also counted. And this is what's happening in aviation for years. Of course, if you look at the To Err is Human at the US, these are the numbers of people die every year because of medical errors. It's like 2 jumbo jets full of passengers crashing every week. This is just from medical error in the state. So the amount of death, that's of course in the US. In my country, your country, this has never happened. Nobody died because of medical errors. I think this is global, everywhere. And the author of this report made it very clear that licensing certification for health professionals should place greater attention to safety and performance and competence. And the same, the chairman of the American Board of Internal Medicine, that it is very imperative to use simulation. And since then, the Internal Medicine Board at the States using simulation for assessment. And that's why even in the Saudi board, we use simulation, not only oral exams and MCQs. We want to see whether people could perform under stress and they could demonstrate competence. This is the anesthesia program in Saudi Arabia. I was part of the upgrade. And now, like aviation, every graduate anesthetist have to finish this key requirement before they sit for the exam. And we were able to increase the number of enrollment in Saudi Arabia without compromising the number of, or the quality of the training by integrating simulation in Saudi Arabia. So now we have 500 people in the program, and we use simulation for training and exams. Doesn't matter where you go in Saudi Arabia, the basic and advanced skill crisis management is part of the requirement. And this was have received international recognition from Royal College of Canada, Society of Simulation, and Middle East regional recognition. So what are the ranges of simulation and where it's used? Of course, it's used in all these areas. Of course, if you think, how did they go to space? Did they just go to space like this? They started with simulation, plan, do, check, act. This is what they do for years in engineering, war. This is the way they go space and coming back. This is the way they do it in wars, in boxing, sports. Everybody go to simulation. They have these drills to simulate. So in healthcare, there are 5 or 6 types of simulation. Verbal or standardized patients actors, where communication, conflict management, teamwork is being taught. In anesthesia, we use this a lot. You could use this as stage, you could record it. Now there's electronic forms for basic and complicated, with moulage, without moulage. Part task trainers, I'm sure you've seen a lot of these things. Now there are 5,000 different systems and skills that you could use part task trainers for all type of blocks, all type of procedure in anesthesia and many areas, and this is expanding. Of course, now some of these things actually come into clinical practice. This is simulated ear, but it's actually implanted in biodegrade in biosolution, and then implanted for tissues, and then implanted in patients. So this is simulation actually used in patient. The same is done for heart valves. Virtual simulation, you could replicate on computer screen. You could do tasks. And now this is the interesting thing, you know, like if you watch the coming 10 years, you could have hyper augmented reality. You could have things, eyeglasses, you see, then the images that simulated in the CT scan could be showing up in your patient. So that's the mix between simulation or hyper augmented reality and healthcare. And that's coming very soon. And actually there are a lot of application, a lot of research. For example, this is like a vascular tree or angiogram. Through reconstruction, you could actually see it on the patient anatomy in the OR, and you know where you will go. And we could see a lot of applications in our operating rooms for these technologies. High fidelity simulation is in which you use all of the above. Computerized mannequins, role play, hybrid simulation, you mix actual teams. These are the ones from our center and other centers. This is actually from our OR. This is in situ high fidelity simulation for fire in a neuro case and how to evacuate the room. This is actually teams, actual neurosurgeons, and then going through the problem with wires and then reconstruction. This is the mobile unit that we developed. We could do high fidelity simulation. This was in المشاعر المقدسة في المدينة في مكة المكرمة وعرفات. This year when we had Corona and we need to train people in Medina al-Munawwara and there was an outbreak, we sent this car from Riyadh to Medina, high fidelity simulation carried on in 5 days to prepare physicians to expand ICU facilities, and that actually happened. They increased the critical care by using simulation, using these mobile carts. These are the inside of the car. It's like an OR or ICU. People sit down, and then this is a high fidelity simulation program that we started during March, September this year at our center. We managed to train over 2,500 clinical staff for PPE, airway, in situ simulation, and prepare our hospital And though we were the second major hospital to receive cases, we have staff infection at below single-digit % so far, alhamdulillah. So simulation is everywhere. It's coming. It's actually day-to-day practice in many institutions now. And these are the questions that we always ask. You know, like every time simulation comes, these are the questions that people ask. What we want to teach. We could teach all the basic knowledge, skills, and domain. And the most important thing is the situation awareness and teamwork. That's very difficult to train in other areas. We could train individual, team, healthcare system. This is what we do, for example, at the border with Yemen now, you know, like how to manage difficult areas because there are not enough critical care physicians at the war zone. So we do this training, we go there at the Jabha, and we train people just at the border, Najran, Jizan, to prepare them for the crisis. When we had the Ebola outbreak in Africa before Hajj, we trained all our hospital staff for the first Ebola case that never made it, but our hospital was ready for the Corona, the MERS-CoV, and then the Corona, we use the same model to enroll. So any clinical environment could be simulated. It depends on the needs. You could have experienced anesthesiologists, practitioners, because we know when crises happen, those are very rare. Nobody is always ready for crisis. So we could always test critical and or clinical and non-clinical situations. And this is what they had discovered in aviations for years before, and developed what they call crew resource management, how the cockpit managed. And now in medicine or anesthesia, it's non-technical skill or crisis resource management, in which depends on technical skills and also behavior and teamwork, like situation awareness, cognitive components, knowing the environment, teamwork, leadership, communication, these are the skills that are key and the most important, the efficient in crisis management and results in most of the critical incidents. So usually we bring different teams. We focus 60% on the behaviors and 40% on the technical or cognitive skills, but 60% was on the teamwork behaviors. And the most important thing, the learning happened. Simulation is very important, but the most important thing for learning is the debriefing. When people sit down and then they see the video and then, oh, did I do that? Did I miss that? Why did I miss that? And that's the reflection on action, what shape. Now we have a lot of graduates of our program. They say, oh, I had a crisis, anaphylaxis. I managed it. It's not the first time. But then when it's over, I discovered the last time it happened, it was not actual. It was the simulation. So these things are transferable to practice. As I said, we use this for Hajj, for in Medina, Mecca. We do this now at the national stage, at the national conferences in simulation. This is our first conference. Since then, we had four international conferences like this. And it's very well expanding in OR. We started with anesthesia, emergency medicine, critical care, and now it's expanding to many other areas in the hospital and in clinical situations. Does it work? Is there an evidence? Is it worth the time? If you want to look at from aviation, these are the data from the 1960 to the 2000. Those are the numbers of projected traffic. If nothing done, this is the number, the top line is the number of accidents expected. But the number of accidents actually recorded is the one here, the accident rate. You could see very clearly that the number of the traffic, the same from military aviation. And that's big time. Of course, a lot of system changes happen, but simulation was very important. as Professor Majdi said before, we always measure the impact of simulation. So satisfaction, learning is level 2, impact, results, and the most important and the difficult is the return of investment. Can we prove that simulation, training with simulation save life and cost? This is, of course, have happened in military and aviation, and the evidence in medicine is there. So this is one published in 2013 in Medical Teacher. They compared the difference, like the satisfaction, that's level 1, knowledge outcomes, that's level 2, skill or outcome, that's level 3. It's always there is favorable for simulation-based training to be superior compared to other things. Of course, there is problem using simulation to train or to assess competence because these things are very rare. So there is no gold standard for measuring performance. Need to use simulation to test simulation. There is a lot of and intra-individual variability that require large cohort of subjects. So it may be a study that will never be ever. Aviation and no other industry have weight to unequivocal proof to use simulation. It's like you want to test parachute. So you have to send 100 people out of an airplane with no training, or with no parachute, and 100 people with parachute. It's not doable a study, because now if you apply for ethics that you will train some people with simulation and with other people with no training or no other simulation, no board will allow you to do that. It's unethical to do that. That's the amount of evidence that. So level 5 is the return of investment for implementation of crew resource management. This is a study came 2015 and published at the American Journal of Medical Quality. They looked at integration of high fidelity crew resource management at 12 at multiple centers in the States. It cost them 3.6 million US dollar in direct and indirect costs, and they calculated the return of investment, amount of reduction, and the saving from 12 million to 28 million, the amount of saving from the medical errors were noted in that paper. So it was a very clear evidence that crisis resource management, even at academic centers, could reduce the number of expected events to 25% reduction. So going back to the cases, just to tell you the importance, this case happened actually when I was a chairman. I just remind you, this is a 50 years old male post cabbage for rebleeding, cardiac arrest 5 minutes of opening the chest. CPR was done for 25 minutes. Till the senior anesthetist came, he checked the tube was disconnected, but the patient have hypoxic brain damage and died. So what to do? Actually, this was an emergency case. It was new anesthesia machine with it was a new Zeus, but the team never had training on it. It's a new surface. That was the start of the cardiac surface, and the senior was not there. The doctor who took on the case was not trained on the machine, so he'd never been in that room. The chest was open. The lung was not inflating for 25 minutes in front of the surgeon, no CO2, and nobody paid attention. And the staff were not trained on that machine, and they had no crisis management training. So there's not only one thing. There you could identify a lot of reasons why that thing happened. It's not because the doctor is ignorant or stupid or blind, because there are a lot of things beyond the doctor. It is something in the system and setup. This is the other case. 8 years old boy, fine needle aspiration under GA at radiology, cardiac arrest after 5 minutes after induction. CPR was done for 35 minutes with 15 senior doctors around or more. The return of vitals happened when they used ambu bag with room air. The patient came back. The patient developed post-operative hypoxic brain damage and died. So this was, again, supposed to be an emergency case, but it's semi-elective, so the booking was not right. There was a nitrous oxygen switch in the wall. It was at radiology suite. Anesthesia machine was not checked by the technician, not the doctor. New surface location after pipeline changes and upgrades. So biomedical people did not check the oxygen outlets. Anesthesiologist did not check. The technician did not check. No handover of the place. So no documentation that maintenance was done or changes. And people did not have any training in crisis management and had no information that maintenance was done behind the wall. So, and of course, they missed a lot of things. So there's not only one or two reasons why crisis or bad outcome. It's a lot of things from the company, from the hospital, biomedical engineering, anesthesia technician, anesthesia department, doctor, check, and till the patient had the catastrophe. So I think we need to keep training to lead the way to improve patient safety. Anesthesia care is complex and under pressure. Not only reducing mortality is the aim is to have safety. Can you imagine that in aviation, they tell you, we'll take you from Cairo to London, but you will arrive, but with broken leg or with broken teeth. That's not, if you think healthcare is safe, think about what pilots do. Do you think pilots ask who's going tomorrow from Cairo to London or to Jeddah? Who's flying? So I will send or not send my wife or kids or travel? No, they don't, because they trust the system. But ask each of us, if a relative going to a hospital, who's giving the anesthesia? Who's doing the surgery? Because we don't have that level of safety. So there is, we need to have a lot of changes so we could go to hospitals and not ask the question, who is there? I think simulation-based training has current and future great potential. With Corona or without Corona, performance improvement comes from deliberate and reflective practice. If we do not reflect, if we not practice even rare events, we become rusty. We need to adapt various levels of training to improve individuals, team, and organizational improvement. I always say, I was lucky in 2012 when I applied for my BLS exam for the first time since I came from Canada, that Professor Kaki signed my card. I think if people join simulation as faculty now early on, they will be the one who will be signing the cards for others. If you wait, I think somebody else will be signing your card, because I think in 5 or 10 years from now, everybody like aviation, like pilots, will come for simulation training every 6 months or every year, because it's just unbelievable that we go through years of practice, maybe no crisis, and no retraining happen. So I think whatever we have today will change very soon, and many countries already started using simulation for recertification. And in Saudi Arabia, I hope in 2-3 years that will be reality. It will be in terms of courses and CRM recurrent training. Thank you very much. I also like to thank my team at the center and the department, and I'll be happy to take any questions. Thank you for the kind invitation again, and happy to take any questions.
Thank you, Professor Abdulaziz. Actually, it was a very excellent lecture, not only about simulation, its importance, but about the safety of anesthesia and ICU as regard morbidity and mortality. You touched the culture of not to blame and stop the technique of ABC in incident management, that we please stop, keep questions a little bit, Walid.
Okay.
You are hurried to.
It's okay.
First of all, we should stop the technique of ABC when an instance happened. Accuse, blame, and criticize, and ask about you excellently explain the technique of what, not who, as regard reflection and feedback. Feedback is very important, and reflection is also very important. We will start by the second step of Kirkpatrick. You highlight the 5 steps of Kirkpatrick as regards the reaction, which can be later by the poll about the excellence of the lecture, and then transfers knowledge. We now will compare about the answers of the first 6 questions before and after the lecture, and the third lecture, what will we change and when we go back to our hostel, we might get benefit from this lecture and to start to train by simulation, and then five steps as you explained in Kirkpatrick. Now you can, before keeping the actions of the candidates, please, Walid, expose the questions, 6 questions to be answered again. By the way, they are the same answer to just how knowledge has been transformed to your knowledge. Start, and please press next after your answers any question.
I'm really interested to see and compare the results of the 2 polls, Prof. Abdulaziz. Just to mention one thing, please, who did not attend the first vote, don't vote in the second one so we can compare the instance of differences, if there is any. So who did the first one, do the second one, please. And who did not attend the first one, please refrain or avoid doing the second one. Thanks very much.
Can you display the first results and the second results? Or you could do the comparison later.
And I'm afraid this is not possible during the Zoom. So if you're doing a poll, you cannot share the result of the previous poll. But we can put them in 2 slides and show at the end. By the way, a lot of attendees are really interested to know the right answer. So if you don't mind, I will post the right answers after we finish the second poll. Is that okay?
Walid, I have an idea, please. You can, during the next 5 minutes while we are discussing with the attendees their questions, you can do 1 slide of PowerPoint of the 2 pictures.
That can be done. That's fine.
Okay. Let me do you finish the poll?
We still have 2 minutes more.
Okay. I'm very happy to discuss with Professor Abdulaziz some about his comments about this simulation and training. And I've said in the previous discussion that the one who falls in love with education never forget about that.
Yes. I attended with Professor David Gaba a few years ago in the International Medical Simulation Conference in the States. And actually he put a very big slide with verses from Torah, Injil, ومن القرآن. ومن أحياها if people say uh, that you need evidence. For him هي الآية دي ومن أحياها فكأنما أحيا الناس جميعا. If it's only one life, وأنا دائما أقول للزملاء والزميلات in my life when my brother arrested in ER and there were no cardiologists and I was managing his arrest, 5-time arrest in ER, فضل الله سبحانه وتعالى, he's still alive. I don't think it's anesthesia. طبعا فضل الله أولا وأخيرا ثم crisis management training. For me, I already had that life saved, at least one life. And I know so many other lives from reports from people attended the training. They called and say, oh, I saved this life because I had that training before. And Alhamdulillah, Rabbil Alamin, I've seen a lot of evidence. And if it's only one life out of the 1,000 people who attended our courses, that's way more than enough as an evidence, as a reward, inshallah.
Walid, you finished? You finished the poll? Can we go to discussion?
1 second. Yes, we just finished now.
During our discussion with Professor Abdulaziz, you can go to do one PowerPoint slide and we'll make you to share screen. We'll accept you to share screen. Professor Abdulaziz, the first question, I think you answered this, but you might highlight better again. Is simulation enough for training in BLS, ACLS courses? What about online courses like ACLS? Thanks for nice session. I think during the lecture you answered this with evidence-based, but I think he is a little bit in need to do more about this point. Ali Saad.
You know, it all depends. BLS for whom? What's the impact or the training for this person? For example, if somebody is practicing anesthesia day in and day out, or in emergency medicine and they have a cardiac arrest every 2 weeks in ER, then they practice CPR and, you know, like that training, you know, like either on person or online, you know, like it will improve them, you know, like it would make no difference. But if somebody is facing this very rarely, they have to have more hand-on training. So it depends on the exposure. Are you rusty? Is the person rusty? Is he more likely to use these skills very soon? The more they do it, the less training they need because they just do it every day, like IV cannulas. You know, like if you work in the OR and insert IV cannulas every day, you do not need training for it because you're competent in doing it. So it depends on the skill, person, and how much exposed to the thing. And of course, not all people, not all categories have the same requirements and the same utility for training. So we have to individualize to groups, individuals, and teams. For example, Corona, it's new. Everybody is new when it came. So we use simulation, you know, how to work with BBE, full gear. You know, like we're experts with BBE, but not that with poppers and, you know, like how to communicate and how to find things and how to get things from outside the room, how not to contaminate others. Of course, we are all senior anesthetist experts, but you could see that, you know, simulations saved life because it was actually very, they have the same feeling, you know, the hot, the sweating inside. So when they had the first cases, it was not the first time. So I don't think only online teaching will do. You need to combine with other hand-on or more intensive forms of training, especially for the complicated stuff. I hope I answered the questions.
Okay.
Also, I try my best to keep in time. So we started 12 minutes, but I kept to
Okay,
the time.
you are pretty tight. If we can rephrase the question that is simulation, is it enough for competency or capability?
Okay, I give you a very good example. This is always quoted in aviation.